Okay, so today we start our discussion of airspace disease. And when we're dealing with airspace disease, we can basically say that alveoli can be filled with certain kinds of substances. So if they're filled with air, we call that pulmonary edema. If it's pus, we call it pneumonia. If it's blood, it's pulmonary hemorrhage. They can be filled with cells with conditions like bronchoalveolar carcinoma or sometimes lymphoma. It can give you an infiltrative appearance in the lung parenchyma with air bronchograms. And a rare disease like pulmonary alveolar proteinosis, there the alveoli can be filled with protein. So we'll start with this case. Here we have the chest x-ray on admission, and we see that the patient is on a backboard. The lungs are relatively clear. And just 6 hours later, we have the development of these widespread bilateral consolidations. Now, when we have development of acute bilateral consolidations like this, the most common etiology is usually going to be pulmonary edema. And when we're discussing pulmonary edema, we try to divide it into two categories, and they are cardiogenic or non-cardiogenic. Looking at the heart can help us. If the heart is normal in size, then usually we're dealing with non-cardiogenic pulmonary edema. So in this case, we'd have to think of some reasons why this patient might have non-cardiogenic pulmonary edema. Certainly in a trauma patient, this can occur with shock lung or ARDS, but there can also be various other causes of non-cardiogenic pulmonary edema that we will also be covering. So as we said, when we're dealing with pulmonary edema, we want to divide it into cardiogenic or non-cardiogenic, and then a major etiology under non-cardiogenic will be ARDS. There will be other causes also of non-cardiogenic pulmonary edema. And today we will also cover unilateral or asymmetric pulmonary edema. So in medicine, they divide the pathophysiologic categories of pulmonary edema into this classification. You can have increased hydrostatic pressure, you can have permeability edema with diffuse alveolar damage or diffuse alveolar damage, essentially ARDS. You can have permeability edema without ARDS, or you may have a mixed edema. But in radiology, we want to keep it simple, so we will divide it into cardiogenic pulmonary edema caused by increased hydrostatic pressure, or non-cardiogenic pulmonary edema caused by increased permeability of the alveolar capillary membrane. So pulmonary edema, cardiogenic pulmonary edema is caused by increased hydrostatic pressure. So we can see this with congestive heart failure. We can see it with fluid overload. We can see it with renal failure. And here you have a typical appearance of pulmonary edema with bilateral perihilar consolidations. This has been called a bat wing or butterfly pattern of consolidations. And this may be associated with fluid overload pulmonary edema. Now you do need to be familiar with these numbers, the correlate of the pulmonary venous wedge pressure, and what is the finding on the chest radiograph. So normal is less than 12 millimeters of mercury. At 12 to 19, we get grade 1 pulmonary venous hypertension where we see cephalization. At grade 2, we see interstitial edema. And grade 3, at greater than 25 millimeters of mercury, then we will see alveolar edema. Now with chronic disease, the venous pressures are usually 5 millimeters higher for each of these categories. So with grade 1 pulmonary venous hypertension, we get vascular redistribution. Normally, the upper lobe vessels are smaller than the lower lobe vessels, especially on an upright chest radiograph due to differences in hydrostatic pressure. However, if there is redistribution, then we will see prominence of the upper lobe vessels, and here we see this vessel here, which is really these are pulmonary venous branches. And there may be other clues that we're dealing with increased intravascular fluid volume or cardiac conditions like cardiomegaly and widening of the vascular pedicle. So in this case, we see some mild pulmonary venous congestion here with these prominent vessels in the upper lobes. Notice also that the vascular pedicle here is widened to the right as the superior vena cava is distended. So here is the same patient with increased intravascular fluid volume. You can see the distension of the superior vena cava compared to normal. That's what the normal superior vena cava looks like in this patient. And this patient also has distension of the azygous vein when the increased when the intravascular fluid volume is increased. You can compare that to this example here. So the vascular pedicle is from the right border of the superior vena cava to this vascular border on the left, which is caused by the left subclavian artery. With increased intravascular fluid volume, we get widening of the vascular pedicle to the right as the superior vena cava gets distended. Now with grade 2 pulmonary venous hypertension, we have interstitial edema. Here we will see Kerley B lines. We might also see Kerley A lines and Kerley C lines. And these increased interstitial markings, they represent thickened interlobular septae. You may also have parabronchial cuffing, Hyler-Hayes, thickened fissures from subpleural edema. So it's important to know what these terms mean. What are Kerley B lines? What are Kerley A lines? What are Kerley C lines? So Kerley B lines are these lines in the periphery here. All of these represent thickened interlobular septae. Kerley B lines occur in the periphery, and they make right angles here with the pleural surface. Kerley A lines radiate out from the hyla, and Kerley C lines, this just represents superimposition of the A lines and the B lines. And so here's an example of interstitial edema in somebody with Kerley B lines. We can see these lines here in the periphery, and this patient also has a small pleural effusion, which we can see here on the right also. Here's a close-up of that case, and it's showing you again a nice demonstration of the Kerley B lines here in the periphery. In this patient with a right effusion, we can see some interstitial thickening here, also radiating out from the hyla. And here's a patient who has interstitial edema. We can see the thickened interlobular septae here on the CT outlining these secondary pulmonary lobules. This patient also has emphysema, which really outlines the secondary pulmonary lobules nicely here. Here's another example of thickened interlobular septae from interstitial edema. And interstitial edema can be mistaken for lymphangitic carcinomatosis. Interstitial edema gives you smooth interlobular septal thickening, although lymphangitic carcinomatosis can give you smooth thickening. It is more commonly associated with nodular interlobular septal thickening. So interstitial edema does not give you nodular interlobular septal thickening. So if we see nodular interlobular septal thickening, we need to think of other causes, especially lymphangitic carcinomatosis. So here's a patient who was short of breath in the emergency room, and we evaluated this patient for pulmonary embolism, and we can see here on the CT scan the reason for this patient's shortness of breath. We see the smooth thickening of interlobular septae here outlining secondary pulmonary lobules. So this is a patient with interstitial edema. With grade 3 pulmonary venous hypertension, now we get alveolar edema as the fluid spills out into the alveolar spaces. And we may see a perihilar distribution or a batwing pattern of consolidations. It may predominate in the lower lungs. You may have other clues directing you towards pulmonary edema, like pleural effusions and cardiomegaly. With pulmonary edema, the consolidations may change rapidly, and the distribution may also be dependent on the patient's position. And we've seen this bilateral perihilar distribution of consolidations, the so-called batwing or butterfly pattern of consolidations, classically associated with pulmonary edema. Here we have a 44-year-old woman who presented to the emergency room with acute onset of shortness of breath, and we can see that the patient's been intubated here. There's a nasogastric tube also in place, but there are these bilateral consolidations, and of course the differential includes many things. Nowadays it also includes COVID pneumonia, but this patient with bilateral consolidations, here on the CT scan, we see these ground glass opacities and bilateral pleural effusions and some consolidation here in the left lower lobe. There is some mild interlobular septal thickening here. So this is another patient with pulmonary edema. Now, when we look closely, we can surmise the cause of the pulmonary edema. Notice that the left ventricle here is slightly dilated, as is the left atrium. And if we look very carefully in the subendocardial region here, we can see here this area of hypoattenuation. Now remember, this is a CT scan for PE. This is not a cardiac CT, but we can still reformat this into cardiac planes. So here's a two-chamber view. Here are short axis views. And on the two-chamber view, here we can see this decreased perfusion in the subendocardium along the anterior wall. Also confirmed here on the short axis views, this was a patient who was having a myocardial infarction, and that was the cause of the pulmonary edema in this case. And here is the coronary angiogram on this patient. The patient did have elevated enzymes, and we can see that this very severe narrowing of this obtuse marginal branch coming off the left circumflex artery. So this was the culprit artery leading to this patient's acute heart failure and pulmonary edema. Now, what is the most common cause of cardiogenic pulmonary edema with normal heart size? Usually we associate pulmonary edema, cardiogenic pulmonary edema with a big heart, but the most common cause of cardiogenic pulmonary edema with normal heart size is myocardial infarction, acute myocardial infarction, similar to the case that we have already seen. Another cause of cardiogenic pulmonary edema with normal heart size is acute cardiac arrhythmia. Now here we have a patient who has these bilateral ground glass opacities with interlobular septal thickening. Notice also when we look inside the secondary pulmonary lobule, we also see some reticularity actually inside the lobule. So this patient has both interlobular and intralobular septal thickening with patchy areas of ground glass. This appearance is called crazy paving. Now, usually we associate crazy paving with pulmonary alveolar proteinosis, but this is a patient with pulmonary edema. Pulmonary alveolar proteinosis is a very rare disease. So if you come across a case of crazy paving in clinical practice, it is more likely caused by some other disease. Pulmonary edema is very common. It can occasionally give you crazy paving. Other diseases that can give you ground glass opacities with crazy paving, we might see that with pneumocystis pneumonia, and we can also see that with viral pneumonias. Here's a 50-year-old who had a CT scan, again as a PE protocol, concerned about pulmonary embolism because of shortness of breath. And again, we see bilateral ground glass opacities with some interlobular septal thickening. Again, a pattern of pulmonary edema. What drug can do this? And this was a patient who had an overdose of heroin. So heroin and opiates can also cause acute pulmonary edema. And then here in this example, we have the centrolobular ground glass opacities with interlobular septal thickening. Notice when we actually look inside the lobule, you can actually see a gravitational gradient where the ground glass seems to be denser along the dependent portion of the secondary pulmonary lobule. So an actual intralobular gradient here in somebody with pulmonary edema. Noncardiogenic pulmonary edema is caused by damage to the alveolar capillary membrane, so there's increased permeability. A very common cause is ARDS, and then there are other causes also that we will discuss. We saw a case of opiates that can also give you pulmonary edema. So there are many causes, as listed here, of noncardiogenic pulmonary edema. ARDS is a very common cause, so this occurs from alveolar capillary injury resulting in leakage of edema fluid into the alveoli. The edema is prolonged because the fluid has protein and is high in terms of the oncotic pressure, so resorption does not occur very readily. And these patients require high concentrations of oxygen and high ventilatory pressures to overcome the decreased lung compliance because the lungs are very stiff in these patients. And you can see in this example, they have bilateral consolidations, as you see here, and a common complication is barotrauma. So you can see the extensive subcutaneous emphysema here in this patient because of barotrauma. So etiologies for ARDS, there are many. Trauma is a very common cause, shock, sepsis, burns, and then other etiologies that are listed here, but ARDS is very common to see as a cause of noncardiogenic pulmonary edema. So the the histologic pattern associated with ARDS is diffuse alveolar damage, and this goes on, ARDS progresses into various phases. There's the acute exudative phase where we get hyaline membranes and protein-rich edema fluid with remnants of necrotic epithelial cells. This occurs on days 1 to 6. And then there's a phase of proliferation of type 2 pneumocytes. That is the subacute proliferative phase. This occurs on days 4 to 10. And then there's the chronic fibrotic phase where we get organizing fibrosis of the fibrin and the exudate that is accumulated within the alveoli, and this usually occurs after day 8. Here we see the acute exudative phase. We see all of this material here that is leaked out into the alveolar spaces. It's interesting that the fibrosis from ARDS occurs as fibrosis of accretion, meaning that that material that is spilled out into the air spaces is incorporated into the alveolar walls by fibroblasts, as opposed to the fibrosis that we see with interstitial lung diseases like idiopathic pulmonary fibrosis or UIP. Here the fibroblasts are in the interstitium, and the fibrosis occurs within the interstitium. So here we have an example of the diffuse alveolar pattern going into the fibrotic phase. You can see the organization as the fibroblasts have incorporated that material into the alveolar walls and the thickening of the alveolar walls. Now this usually progresses in terms of overlapping phases, so you might see this diagram where you get the phase of edema, hyaline membranes, and then the fibrotic phase, but all of these can overlap as the disease progresses. So with ARDS, the findings may be delayed up to 12 hours after the onset of symptoms. So initially the chest x-ray may be negative even though the patient is acutely symptomatic, and then a few hours later you may see widespread bilateral consolidations. The consolidations persist for days to weeks, and then they may progress to fibrosis. Another characteristic of the consolidations is that they can be gravitationally dependent, because much of the opacity that we see really represents stiff, collapsed lungs. So the lungs are very stiff and they collapse under their own weight. So this gravitational gradient to the consolidations is quite common. You can also see these areas of ground glass opacities elsewhere throughout the lungs. So these patients can be treated by rotating the patients to try to even out the oxygen distribution throughout the lungs. So you can see here when the patient is supine, that gravitational dependence of the consolidations mostly posteriorly after the patient has been prone for a period of time. And then on this scan you can see that these opacities have migrated more anteriorly in the more gravitationally dependent position. So ground glass opacities, we may also see that with ARDS, as you see in these examples. And then when it progresses to the fibrotic phase, we will get traction bronchiectasis. We don't get honeycombing with ARDS. So the traction bronchiectasis here is manifested as these beaded airways here within these areas of consolidation. Complications of ARDS, barotrauma is very common, as these patients have to be treated with high ventilatory pressures in order to oxygenate them. So we can get pneumomediastinum, as you see here, and then we can get that can extend into the subcutaneous region. So we get subcutaneous emphysema. We can have pulmonary interstitial emphysema, pneumatoceles, of course. We can get superinfection and pneumonia, and then progression to lung fibrosis. Interstitial emphysema is unusual in adults, but you might see these irregular air collections here dissecting out along the interstitium as a result of barotrauma. And then pneumatoceles can also occur as a result of the barotrauma. The air tears into the interstitium, and you get these interstitial round collections of air called pneumatoceles. And then when the disease progresses, we can have fibrosis, and the fibrosis manifestation of that can be reticular opacities, as we see here, and traction bronchiectasis, as we see here on the CT. Now, another interesting finding is that the fibrosis can be more so in the anterior regions of the lung, because it is thought that the fibrosis occurs as a result of oxygen toxicity. So when the patient is supine, because of the gravitational dependency of the opacities, that the dependent lung parenchymas are protected from oxygen toxicity, so the oxygen then goes more towards the anterior lungs, and then here is where we can get a predominance of these fibrotic changes. So consolidations then in the acute phase, usually more in the dependent regions of the lung, and when a patient recovers and has fibrosis, the fibrosis may predominate in the anterior regions of the lung, as in this example. So here's a case from our institution that shows these ground glass opacities anteriorly, some irregular airways here representing traction bronchiectasis, and here on this MINIP reconstruction, we can see that the fibrosis here is predominantly anterior in this lung in this patient who recovered from ARDS. Now, a few definitions. Diffuse alveolar damage. This is the histologic pattern of injury. Acute lung injury is a clinical syndrome associated with this particular pattern, and there is a definition for that as the PaO2 to FiO2 ratio less than or equal to 300 millimeters of mercury. And then there is ARDS, which is this clinical syndrome where we get acute symptoms, diffuse pulmonary opacities, exclusion of cardiogenic pulmonary edema, and the PaO2, the FiO2 ratio is less than or equal to 200. An AIP, or acute interstitial pneumonitis, that is an interstitial lung disease, which is essentially idiopathic ARDS. Now, it can be difficult differentiating cardiogenic pulmonary edema from ARDS. With cardiogenic pulmonary edema, the infiltrates usually coincide with the symptoms. With ARDS, the consolidations may be delayed, may occur after the onset of symptoms. With cardiogenic edema, we get perihilar consolidations, peribronchial cuffing, septal lines, and air bronchograms. ARDS will affect all the lung zones. Peribronchial cuffing is less common. Septal lines also less common, as are air bronchograms. The consolidations can change rapidly, especially with gravitational positioning with cardiogenic edema, and they change very slowly and resolve very slowly with ARDS. Cardiogenic edema can be associated with a widened vascular pedicle, telling you that the intravascular fluid volume is increased. With ARDS, the vascular pedicle is usually not widened. And with cardiogenic edema, we may see cephalization. There's no cephalization with ARDS. You might see pleural effusions with cardiogenic edema, and pleural effusions are not present or small with ARDS. Now, there are other causes of non-cardiogenic pulmonary edema as listed here. There are very many causes of non-cardiogenic pulmonary edema. Here are a few more: silofiller's disease, smoke inhalation, toxic chemicals. These chemicals can act as irritants to the tracheobronchial tree and the alveoli, damaging the alveolar capillary membrane and then causing non-cardiogenic pulmonary edema. So what is the cause of silofiller's disease and what is the long-term complication? With silofiller's disease, this occurs in the first few days after a grain storage silo is filled. Nitrogen dioxide forms. That nitrogen dioxide can react if it is inhaled with the water in the respiratory tract, and forming nitric acid that acts as an irritant to the tracheobronchial tree and the alveoli. In the acute phase, patients develop consolidations and an acute bronchiolitis and pulmonary edema. And one sequela of that can be damage to the small airways. Weeks to months later, these patients can develop bronchiolitis obliterans. So you'll see air trapping here as a result of the damage to the small airways, and here we have a little bit of bronchiectasis involving airways because of damage. Smoke inhalation. This occurs acutely after smoke inhalation. The patient may be asymptomatic initially after smoke inhalation with a normal chest radiograph. That's why the clinicians will look for soot around the face, the nose, and the mouth, and elevated carbon monoxide levels to tell you that the patient is at risk for smoke inhalation, because 24 to 48 hours later, the patient may develop pulmonary edema. Opiates, as we've said, this is another cause of non-cardiogenic pulmonary edema, and this may be permeability edema secondary to hypoxia and acidosis. Cytokines used in chemotherapy, this can also be a cause of non-cardiogenic pulmonary edema. Near drowning. Prolonged hypoxia can damage the alveolar capillary membrane. Initially, the consolidations we might see in a case of drowning. Remember, this was the case that we started our lecture with. This was a case of near drowning. Initially, the consolidations that we see may represent aspirated fluid, but as a result of the aspirated fluid and the contaminants within the fluid that damage the alveolar capillary membrane, even when that fluid is cleared, the patient may go on to develop non-cardiogenic pulmonary edema. So here is a patient who has a fracture here of the ring of C1 and comes in with this bilateral consolidations, which again represents non-cardiogenic pulmonary edema. In this case, this is neurogenic pulmonary edema. So acute injury to the brain or spinal cord can result in a hydrostatic edema as a result of sympathetic nervous system discharge and permeability edema from endothelial damage. So we can see the centrilobular consolidations here with interlobular septal thickening. Here on the coronal reconstruction, we see that it has kind of an upper lung predominance, which has been said to occur with neurogenic pulmonary edema. This patient had a long bone fracture and then had fixation of the long bone fracture, and then a few days after that developed shortness of breath, went to CT to exclude pulmonary embolism, and we found these predominantly ground glass consolidation. So what does this represent? Well, this represents fat embolism syndrome. So this is another cause of non-cardiogenic pulmonary edema. After trauma to long bones, fat droplets may enter the bloodstream, and the onset is delayed because it's hydrolysis by tissue lipases that form free fatty acids, and it's the free fatty acids that are toxic to the lung endothelium and parenchyma. So the symptoms develop 1 to 2 days after the trauma. Patients may be short of breath and hypoxic. There are CNF symptoms like confusion, stupor, and coma, and then a petechial rash within the skin may also be a characteristic finding. So the chest radiograph can show you multifocal consolidations, a pulmonary edema pattern or an ARDS pattern. We don't actually see the fat emboli on CT. All we see is the manifestations within the lung of the consolidations. Amniotic fluid embolism. This can occur late in pregnancy from disruption of the uterine wall and rupture of placental membranes, and then squames from the fetal skin and mucin from the meconium damage the lung. Acute airway obstruction from acute hypoxia. As patients struggle to breathe, the high negative intrapleural pressures can also result in pulmonary edema. Pulmonary edema can also occur from laryngospasm as that obstructs the airway. It's been said that with this type of edema, the lung cortex may be spared, as in this example that we have here. High altitude pulmonary edema or mountain sickness. This is associated with altitudes greater than 11,000 feet. So the pulmonary edema may occur 3 hours to 3 days after being within the high altitude environment. It is said that the hypoxia and heterogeneous vasoconstriction of the pulmonary vasculature results in pulmonary hypertension and increased capillary permeability. So here we have bilateral consolidations in this patient who developed mountain sickness. Another example here, bilateral consolidations, which we can see on the CT of high altitude pulmonary edema. Now, if I tell you this is a 25-year-old man with cough, fever, chest pain for a week, white count is elevated, HIV test is negative, and we see these bilateral kind of opacities, consolidations predominantly at the lung bases. Certainly in this day and age, we would be concerned about COVID, but I will tell you that this is not COVID. And my question to you, after looking at this CT scan, we have these consolidations here, predominantly ground glass, and also more dependent confluent opacities here at the lung bases. So my question to you is, what activity should we ask the patient about? And in this day and age, that activity turns out to be vaping. So the CDC criteria for the case definition is of a vaping-related illness, is use of a vaping product within 90 days before symptoms, pulmonary opacities on chest x-ray, no pulmonary infection, and no evidence of alternative plausible diagnosis. So vaping-associated lung disease, this is an inhalational injury. There are solvents within the vaping products, and it is thought that the vitamin E acetate and the THC, that these two may especially be related to the lung injury. There are various patterns of lung injury that can be seen, but the pattern of acute lung injury that resembles ARDS is a very common pattern. It's basally predominant. We see consolidations, ground glass, and ground glass opacities. So here in our next case, we have a patient with a chest tube, and we have this consolidation here within the left lung, where we notice it is markedly asymmetric. Right lung is clear. So what could be causing this? Well, we have a case here of asymmetric pulmonary edema, and causes of unilateral or asymmetric pulmonary edema, they can be from re-expansion or reperfusion pulmonary edema, which was the case in this patient. This patient had a large pleural effusion, which was drained by the chest tube, and when that lung re-expanded, the patient developed pulmonary edema within that lung. Asymmetric pulmonary edema can also be gravitational. If the patient were lying left side down, let's say in this case, there may be underlying lung disease that is asymmetric, like COPD. Unilateral edema can occur contralateral to an obstructed pulmonary artery. So if this patient had a large pulmonary embolism here on the right side, that would protect that side from pulmonary edema, so the pulmonary edema would occur on the left side. It can also occur ipsilateral to an obstructed pulmonary vein. So if the patient had obstruction of the pulmonary veins on the left side, then the patient could also develop pulmonary edema on that side. So here's another example of re-expansion pulmonary edema. A patient with a large pleural effusion, a chest tube is placed, the effusion is drained. When the lung re-expands, the rush of blood to that re-expanding lung then results in leakage into the airspaces and re-expansion or reperfusion pulmonary edema. Here's another very nice example. Patient has a large pleural effusion, chest tube is placed, and you can see the pulmonary edema here in that lung, nicely demonstrated on this coronal reconstruction from the CT scan. So, re-expansion pulmonary edema usually occurs after re-expansion of a lung that was collapsed due to a large pneumothorax or pleural effusion. When that lung is collapsed, there's capillary damage from the hypoxia, and when the lung re-expands, as there is now blood perfusion to that lung, the fluid will leak through the capillaries into the lung parenchyma. So the pulmonary edema can occur very soon after re-expansion and usually resolves in a few days. Predisposing factors are complete pneumothorax with gross lung collapse, chronicity of collapse, especially greater than 3 days, or high negative aspiration pressures if the fluid is evacuated too quickly. Now, unilateral pulmonary edema can also occur after a surgical procedure, and here is an example of a patient who had that procedure. You can see the chest tube here on the left side, and you can see the edema here also on the left side. Notice that the right lung is quite emphysematous and quite expanded. This was a patient who had a unilateral lung transplant. So this is a patient who had bilateral emphysema and was treated with a unilateral lung transplant. This is the patient's remaining native lung. This is the transplanted lung. A transplanted lung has been hypoxic, so after that lung is reimplanted, it can develop reperfusion pulmonary edema. Thromboendarterectomy from a large PE can also give you unilateral pulmonary edema. So if this patient, let's say, had a large clot in the left pulmonary artery and had thromboendarterectomy, then there you can develop reperfusion pulmonary edema to that side also. Here's an example of gravitational asymmetric pulmonary edema. This was a patient with renal failure, was lying right side down, and you can see that there's consolidation here mostly on the right side. We can have asymmetric edema with COPD, because where we have the areas of COPD and lung damage, we don't see edema. So you can see the ground glass here kind of asymmetrically distributed in this patient. This patient also has lung cancer that you can see there. Here's another example where this patient has these large bullae here within the upper lobes. So when the patient develops pulmonary edema, we don't see the consolidations where the bullae are because there's no lung tissue there. We see the consolidations here in the lower lungs. So asymmetric pulmonary edema can also be associated with COPD. So as we've said, we can have unilateral pulmonary edema contralateral to an obstructed pulmonary artery. That can be from pulmonary embolism, pulmonary artery stenosis, agenesis, obstruction from lung cancer, or obstruction from fibrosing mediastinitis. And you can have it also ipsilateral to an obstructing pulmonary vein, which can occur from a mediastinal or lung tumor. So in this example, we have a patient who has ground glass opacity here on the right side mostly, with a right pleural effusion. And when we look in the mediastinum, we can see that there is this mass here in the mediastinum which contains some calcification. I'll tell you that this is not a malignant lesion. So what benign condition can give you this mass-like appearance of, it turns out, lymph nodes in the mediastinum with calcification and obstruction of the pulmonary vein, leading to, and also the superior vena cava in this case. You can see the azygous vein here is dilated and full of undiluted contrast. So what condition can do this? What benign condition? This is fibrosing mediastinitis. If I tell you that this is a patient who had a history of a recent myocardial infarction and developed this asymmetric pattern of pulmonary edema, how do we put this story together? Well, then here we would be thinking of myocardial infarction with papillary muscle rupture resulting in acute mitral regurgitation. Acute mitral regurgitation can cause asymmetric pulmonary edema predominantly in the right side, especially in the right upper lobe, as that regurgitant jet is directed towards the right upper lobe pulmonary vein. And so the edema then on the right side, especially in the right upper lobe, will be worse than the edema on the left side. Acute mitral regurgitation is not well handled and will usually put the patient into pulmonary edema if it occurs from papillary muscle rupture. So this is our discussion of pulmonary edema for this session, and I thank you for your attention, and we'll see you next time.